Give me one moment and I will start. Just one moment. Right. Okay. Great. Yes, I hope everyone can see my screen. Just let me know about that. I hope you can see my screen. Then, if not, then I can fix it. Yes. Okay. Great. Thank you. Thank you for the response. Today's topic is meningitis scenario discussion. Okay. I would have definitely preferred and I would have really liked it if someone would have come forward and practiced this scenario, but it's all right. I do understand that it's quite a challenging scenario and there is a lot of speculation around this. So, by today's discussion, what I hope to do is try to help you be at least a little bit more confident in dealing with this scenario. Okay. Now, what happens is because of exam tensions and pressure and the stress and anxiety of the exam itself and what would be my next scenario and all of those things, we try to forget what are the basics which should be kept in mind while dealing with such a situation. What I'm going to do is I'm going to talk you through different scenarios which can happen in the exam, what are you supposed to do, and generally how to go about this station. Okay, right. So let's start. Now, like I said, today we are going to discuss the scenario, history taking, negotiating with a challenging situation, differentials, management, and the rest of which have been going on for a very long time. So if you have any questions, you can drop them on the chat box. I'll answer them after I've finished talking about this, right? Maybe while going through each of the slides, I may not be able to answer. So just leave your questions on the chat box. I'll answer them all together. Okay? Starting with the scenario that I'm going to discuss today says you are a junior doctor in the emergency department. Mr. Timothy Newston is a 28-year-old who has been brought to the hospital with confusion and fever. Please assess this patient and at the announcement, which means at the 6th minute bell, discuss with the examiner your diagnosis. Okay? When you have a discussion with the examiner about the diagnosis, you may find that the examiner is asking you more questions than usual. How do you answer those questions? What should be your replies? I am going to briefly discuss with you about the replies that you should be telling your examiner. All right, moving on. So, what do we know about this scenario and what are we going to do first? So we enter inside the cubicle. So you have read this question, right? You enter inside in the cubicle and what do we do first? Some people say give the painkiller. Some people say no, you have to do the GCS. Some people say no, it's an unresponsive patient. What are you going to do? Kind of puts us in a very difficult situation, especially this particular scenario. What are we supposed to do first? Doctor, should I give the painkiller first? Doctor, should I do a GCS first? Or doctor, this patient was unresponsive when I entered and I didn't know what to do. So if you find yourself in a situation like that, usually that stems from misinformation and not being prepared. Okay, I'm really sorry to break these things, but break to you about this, but then this is exactly what happens. So you think that the wise thing to do would be to give the painkiller first, then the next thing that you should do would be assess the Glasgow Coma Scale, and even after you have done these two things, your patient is still unresponsive, and that kind of puts you in a very difficult situation because you don't know if you should proceed further or you should stop, and the examiner is not very helpful. It's not their fault even, but they're just not very helpful. You just don't know. So before 6 minutes, do not expect any kind of answer, even from the simulator or the examiner. Please do not expect that. If you go with the expectation that someone is going to help you inside in the cubicle, you are setting yourself up for a challenging situation. Please do not harbor those kind of expectations. That's my first advice, right? So what do we do? What do we do in this situation? Ideally, what you're supposed to do is introduce yourself, confirm the identity, activate emergency response system. Now, I'll put it in simple words. What I mean is call for help. Okay, that's what I mean. You just call for help. Whom do you call? The other team members and your seniors. That's about it. That's what I mean when I say activate emergency response system. Establish the rapport. Who do you establish the rapport with? You establish the rapport with the patient. So you want to call, if you enter inside and while you have introduced yourself, you get no response from the patient. When you are asking them, may I know whom I'm speaking to? And you get no response from them, right? So what are you supposed to do in that situation? You are going to verbalize that I'm going to call for help, and then you are going to call this patient by their name. What is their name? Let's go back and see what's their name. Their name is Timothy Newston in my question. So I'm going to call this patient Mr. Newston or Timothy, can you hear me? Right? So I'm going to try to confirm the name and I'm going to try to establish the rapport by confirming the name first. So I try to call them by the name and I don't really hear anything. So let's take the first scenario when I don't hear anything except for some sort of moaning or mumbling. What am I going to do? The next thing that I see that the simulator does is they try to cover their eyes with the help of their forearm, right? Or maybe they might be wearing dark glasses when you enter inside. So expect anything. So the next thing, what you want to do is you want to dim the lights and you say, oh, I would like to dim the lights because I can see that my patient is really bothered by the lights. And then you start looking here and there and there's just no response from anyone. Okay, this is typically what happens. Once again, when you do not get a response from someone, that adds to the stress that I think I'm going to fail this scenario. Okay, so please do not go in with expectations that someone is going to help you. Whether you pass or you do not pass this scenario, it completely depends on how or what you have done inside. Okay, so the first thing that you should do should be calm and composed. Okay, now moving on. If you have another situation where you have introduced yourself and when you introduced yourself, the simulator was speaking to you. They were saying, yes, doctor, yes, I have a lot of headache, I have a lot of fever, I think I have a very bad fever. So if they were talking in the beginning and you are going to confirm the identity, okay, can you just tell me your name and your age? And they tell you, yes, my name is Timothy Newston, I'm 28 years old, and the patient is talking to you and they are basically able to give you a history. They are able to say what was happening with them. So they had a very high fever which was not responding to paracetamol and ibuprofen, and they tell you that along with that they are having a lot of difficulty in seeing the lights. Okay, and this has been going on since morning. They have even vomited twice or thrice and they feel that they have a lot of pain in their body. It's so difficult that they are not able to move any single part of their body. So the simulator tells you all these details and then all of a sudden they go numb or they go quiet and there is no response from them. You are trying to take a history but you do not get any response. Once the response or the rapport has been dismissed, please do not waste time because you have already introduced yourself, confirmed the identity, established the rapport, worked on dimming the lights. What you will do next is call for help. That is, when I say activate emergency response system, that's what I mean, call for help, right? So this is what you will do in the second scenario. You have a patient who is talking to you and then they stop talking to you. It means what has happened to their GCS? Has it dropped? Yes. So their GCS has dropped suddenly right when you were taking the history. So there are two ways this scenario can present. When you say, I would like to call for help from my other team members and my seniors, okay, do not expect that everyone is going to come rushing to help you. It is very important that you verbalize this because nobody expects you to do everything on your own. So the next steps that you do when you're dealing with this scenario is you are trying to show that I do know what is supposed to be done, and definitely I would require help. But before people are going to approach me, these are the things I'm going to do. Okay, so I hope I've made sense in what I'm trying to say. Please do let me know if you have understood what I'm trying to say. When you say things like, I'm going to call for help, that doesn't mean help is going to come in the exam. It just means I'm going to call for help because I know that this is the protocol. However, in the meantime, I'm going to do what is appropriate for me to do as this is an exam situation. Right? Okay. Now, moving on. About dimming the lights. So, like I said, if the simulator doesn't respond to the question when you ask them, are the lights bothering you? Do you want me to dim them for you? And then you are saying, examiner, I would like to dim the lights because, the patient is very sensitive to them right now. And you keep staring at the examiner and you get no response. Please do not do that. There is no need for you to turn and look at wherever the examiner is or whoever is there in the cubicle. Please do not do that. Just stand there, acknowledge the fact that the simulator is sensitive to light. Instead of expecting or doing something like that, just say, okay, Timothy, because the lights are bothering you, I would like to dim the lights for your comfort. End of story. That's it. Just say this. Do not expect anyone to respond to you and waste your time. Okay, am I clear? The phrase that you will say is, I would like to dim the lights for your comfort. Why did I say that is because of this reason, a running commentary. So it is expected of you to verbalize each and every step that you're doing. Okay, this is not wrong. Please don't think that I might sound like a fool doing this. I shouldn't be doing this. I shouldn't be doing that. This was not what was taught to me. Please refrain from thinking those kind of thoughts. You have to do a running commentary. Why? Because if you will not speak, you will not get scores. This scenario runs on a systematic approach of A, B, C, D, E. This is what is being assessed. I would advise always talk, right? Please talk. Please give a running commentary. That is, I'm going to be doing this, I'm going to be doing that, I'm going to be doing this and that. Keep the conversation flowing. If you get a response or you do not get a response, do not stop and think, oh, I didn't get a response, I must have done something wrong. So these are some kind of negative thoughts which will impact your scenario in a very negative way. Please do not do that. Be very confident. And like I said, what you are trying to do here is you are trying to show your examiner that I know what is supposed to be done, or I'm aware of the steps that I'm supposed to use until help arrives to help me. This is the basic of what you should know. Now, one may argue and say, my patient was talking and then they stopped talking, so I immediately did GCS. Is that correct? You have to start with, if you look at systematic approach, breathing, circulation, stability, exposure. Before you start this, what will you do? You will check for response. Okay, check for response. Then start with airway, breathing, circulation, disability, exposure. So these are things that you should remember. So where does GCS or checking Glasgow Coma Scale fall in this systematic approach? Yes, very good. It falls in D. Yes. Okay, so now let's move on to what are the components of A, B, C, D, E. Start by checking their response, calling for help, second thing. Third thing is, I would like to assess my patient beginning with the airway, then moving on to breathing, circulation, disability, and exposure. In the end, I am going to check at my patient's SpO2 levels, right? Now, if you do not have a monitor, what are you going to do? if you do not have a monitor? Let's say, for example, this is not a scenario in which you were given a sim man. Okay, there was just a mannequin which was kept. The mannequin doesn't talk to you at all. It was just, a mannequin which is there. You just know that it's there. That's it. There's nothing else. It's not talking to you. It's not responding to you. Nothing. The question says just go inside and just assess this patient. So you want to know about the A, B, C, D, E in this patient. You want to know about what the observations are, what has been done. So what will you do? How will you find out? What is the patient's SpO2, respiratory rate, pulse rate, blood pressure? Is there something you want to look around for? Yes, very good. You want to look around the room if there is a news chart or there is a file that has been kept. Okay, usually it is kept under or it is kept on a table next to the patient. Okay, and that might be the news chart, which will tell you values of pulse rate, BP, capillary refill time. There may be an ECG attached, a rhythm strip which may be there in the news chart, input, output, everything would be there. So what would you do? Would you comment on it all together? How would you comment on airway, breathing, circulation, disability, and exposure using the news chart? How would you do that? Any ideas? What I would advise is you have a news chart, right? You have all these values in the news chart. The first thing you would look at is SpO2 and comment about it. Second thing you would look at is respiratory rate. Comment about it. What is it? Okay, in this patient, the respiratory rate is 28 or 24, or it can be depressed also, it can be 8 or 7. First, SpO2. Second, respiratory rate. Third comes pulse rate, blood pressure, capillary refill time. If you have an ECG, take a look at the ECG right there. Okay, go systematically, know which part belongs where, and comment about it. Even over there, if you establish a systematic approach, it will look good on you. Now, what I said is always give a running commentary. So I said start with respirate. SpO2 is this level in my patient, so I will start them on oxygen. Pulse rate is, respiratory rate is this much. Okay, I would like to listen to the breath sounds. So you pick up the stethoscope if you have one, auscultate, listen to the chest. If you find something, if it is a sim man, if you can hear breath sounds, if you need to, please order a chest x-ray, otherwise no need. Third thing that you assess is, I said pulse rate, blood pressure, capillary refill time, and ECG. So depending on what findings you have here, I would like to start my patient on IV fluids. I would like to catheterize my patient. I would like to start input-output monitoring. And I would like to send blood for investigations. So you say all of that in circulation itself. Then next comes GCS. Now I would like to assess my patient's consciousness scale. And you assess your patient's GCS, pick up the torch, take a look at their pupils. Before you take a look at their pupils, please do verbalize, I would like to check the reflexes, pupillary reflex on my patient. Okay, and you do it. If you can, you do it. Otherwise, just say that I have done this. I would like to check the temperature. So temperature, once again, look at the news chart. If there are any investigations you would like to request over here anymore, so please do request them. And then you move on to exposure, where you will say that I would like to expose my patient and do a complete head-to-toe examination. By the time you are doing all of this, your time is up, and then your examiner says, okay, doctor, so what's going on with your patient and what do you think is happening? Okay, now, if you come back to the question, the question says, a patient has been brought to the hospital with confusion and fever. Okay, in the beginning, when you tried to speak to them, they were talking to you, and then they stopped. What you did was, you did all of this. So you assessed them, and you found out that this patient has a fever. When they were speaking to you, they said that they are not able to look at the lights and they have a lot of pain in their body. This is all that they told you. When you tried to assess the GCS, it was about 13 on 15. Let's say it was 13 on 15. Okay? When you do a head-to-toe examination, you can see that there is a photograph of a rash which was on the patient. Okay? A photograph may be there, a rash might not be there. So there's a photograph of a rash. So what is your diagnosis? Now, if you see these three conditions, meningitis, encephalitis, and subarachnoid hemorrhage, all three of them more or less they present with the same symptoms, that is fever, pain in the body, sensitivity to light, decreasing consciousness scale score, and focal neurological deficit. These three conditions present more or less the same way. Okay, the added information which might differentiate meningitis from encephalitis is history of odd behavior, subarachnoid hemorrhage, weakness. When you are doing a head-to-toe examination, that's when you will find out about the weakness. You can even find out about weakness in your GCS. My advice would be whatever information you have, back up that with your answer. Okay, if you want to say it is SAH, if you want to say it is subarachnoid hemorrhage, then please remember what are the points you can use from this history. Has this patient told you anything else about the headache? He did not say. He just said, I have a headache, I have a fever, I cannot see the light, I feel a lot of sensitivity to the light, I have pain in all of my body. When you were doing the GCS, it was 13 on 15, and when you did the exposure, you saw a rash. So you are saying it's a meningitis, agreed. But please say why you think it's meningitis. It's because of these reasons. Because when I asked the patient what was going on with you, they said it was this. When I assessed them, I saw this rash. So I did the test. What are the tests? Yes, coming to the tests. What test would you do on the rash? Do you want to check if it's a blanching or a non-blanching rash? Glass test. Yes, very good. Yes, very good. Okay. So I saw the rash. I tried to do the test. Okay. Now, if it is a photograph and you try to do the test, you may not know if it is a blanching or a non-blanching rash. Okay, I agree. But just tell your examiner that I could see a rash, so I want to do a glass test to find out if it's a blanching or a non-blanching rash. The other tests that I would like to do on my patient would be Koenig's sign and Rudensky sign. I want to assess them for this in order to confirm if it is meningitis or any of the other differentials that I suspect. Okay, please remember that you are going to speak the answer in a way that it's an open-minded answer. Here in this scenario, if you go inside and say, definitely this is SAH, definitely this is that, definitely that is this, you may not pass because it looks that the candidate has had prior information of the test, right? That this scenario was going to be asked, and that's why they said this. This is why when you hear people saying, I did everything and I still failed, this is what it means. My advice is always avoid yourself from giving out answers like that. Just say what you saw. So over here I said, yeah, I could see the rash. I could not do the test. So that's why I would like to do it and confirm my differentials, one of my differentials, which is this. I want to confirm that. Okay. Prior to doing Koenig's and Brudzinski's sign, will we try to move the neck? You can ask your patient to do that for you. If you want to assess Brudzinski's sign, you can ask your patient, can you touch your chest with the tip of your chin? Okay. If the patient is moaning and groaning and not really giving you a response, okay, so you still have a doubt. Why? Because you don't know where the pain is coming from. Okay, all you can say is, I tried to assess it, but patient was not comfortable, so I want to confirm this with the help of a senior. It would be a much better approach if you say this instead of saying that I tried to do this and then they were in pain. Okay, so always remember that. It's a very good question, and I answered it on the spot. Okay, but yes, You may not have a real patient inside. Or if you have one, you have asked them to do it in which point? Let me go. Yes, you will assess the signs of Koenigs and Rudinsky in E. Okay, please don't attempt that in airway, breathing, circulation, or disability. You will attempt that in E when you are doing a head-to-toe examination. Okay, please remember that. That's your last part of the station. Yes, that's why I said they can be positive in SAH and meningitis. You are right. That's why I said that. Please do give a differential. Okay, that these are the conditions which are in my mind, and I would like to do this to confirm if it's meningitis or encephalitis or SAH. Okay, so the examiner might ask you, okay, so if your diagnosis is meningitis, doctor, what would you like to do for this patient? Then you have to start speaking about the management here, that you would like to start this patient. You already started this patient on IV fluids. You are monitoring their input and output. If you suspect meningitis, what you're going to do is plan for a lumbar puncture, a CT scan. Does this patient have symptoms of raised intracranial pressure? Can you tell if they have symptoms of raised intracranial pressure? Most probably. Why? Because their GCS has immediately decreased the moment you were in the cubicle itself. So it warrants a CT scan. Okay. So these are the things I would like to do, some more tests. Apart from that, I will do a complete blood count, coagulation screen, send the blood for culture and sensitivity. I would like to do a CBG. I would like to check their blood gases. Also, do a renal function test, a urine routine. These are some of the tests that I would do. Then I would call my seniors, right? And depending on the hospital protocol, shift this patient to an intensive care unit or acute medical unit. Okay, so this is the management that you can talk to your patient, talk to the examiner about. The other thing that you must not miss out is if this patient was brought alone or he came alone, please do call the GP clinic or the family and try to assess reasons why this patient has had this condition. What are the risk factors for meningitis? Immune suppression. It could be because of a condition such as diabetes or cystic fibrosis. So you need to check their patient records, overcrowding in the social history, personal and lifestyle, smoking, drug abuse, alcoholism. These are some of the risk factors why a patient can have meningitis, especially when their age is 28 years of age. I did not go into a lot of complexities of this scenario. Why? Because first thing what I wanted to do was condition you to the fact that over here, do not approach this scenario by doing GCS first. Please remember that commenting regarding what you are doing, going systematically by assessing airway, breathing, circulation, disability, and exposure is what is most important. When you reach exposure, say that you would like to expose this patient, do a complete head-to-toe examination, and check for any rash. If there is a rash, I would like to do a glass test. And I would also like to assess this patient for some specific special signs, such as checking for neck stiffness, Koenig sign, Rudinsky sign. Okay, so all of that comes in E, right? If you follow this approach, you may be able to finish in 6 minutes, but of course, you need to practice. Okay, you need to practice. And when you talk about management, explain it in the form of differentials. If you are 100% sure that this is meningitis, always tell your examiner why you think it is meningitis. If you're sure it is encephalitis, please do tell your examiner that it is encephalitis. The reason is because this patient has this. That's why I think it is this. If you think it's SAH, once again, please back up why you think it is SAH. Okay, so decide in the cubicle itself whether this could be a differential or this is a specific scenario. How would you know that? It depends on if the patient has cooperated with you or not. These are the three differentials. These are the three scenarios which can present the same way. They might have overlapping features. So I've told you points for all three of them. Okay. So like I always say, just because you have information from someone else that this is not a very easy scenario to pass, that doesn't it doesn't have to be true. Okay, so please don't think that is true. Do practice. Now that I have given you a new way of looking at it, I hope that you incorporate this into your practice and it makes a difference to what you do. If you want to practice this scenario with me, right, then just let me know on the WhatsApp group. I will try to make an arrangement in my next session where, we practice two scenarios. I won't go into the discussion of meningitis, I won't do all of this. But what I would do is give someone an opportunity to practice if they want to practice. And I would prefer that it's someone who has attended the session, because then, it would make a lot of difference if you verbalize the steps A, B, C, D, E, Y's and then practiced. It would be a better approach that way. Okay. Right. So coming to questions. In the beginning of the station, do we mention about universal precautions? Not necessary. You are entering inside with by taking the universal precautions. Okay, it is not necessary that you verbalize it at this step. Okay, especially in this current situation, I don't think it is necessary. What is more important is that you approach this situation with an open mind and go systematically. Verbalizing universal precautions is not going to fetch you any extra points. Okay. Do we mention about isolating the patient during management? Yes, like I said, so we will shift this patient to the acute medical ward or the intensive care unit depending on the hospital protocol. That's what I mean when I say that according to the hospital protocol, we will either isolate them or shift them to where it's possible to shift them. Contact tracing and chemoprophylaxis. Again, once again, I said that I would like to call the GP or the family practice, right? Or the family to find out. You are calling the GP and you have contact tracing and chemoprophylaxis in your mind. Okay, that's what is important. Right. Any more questions? Okay. So you can subscribe to my YouTube channel. Please do so. It will help me a lot. And I have a Facebook page by the name Mybythebook. My channel goes by the same name, Mybythebook. There is a link where you can support me by giving any contribution as less as $3. If you would like to, please do so. I'd be really happy. That will definitely help me make more content for all of you. The other thing I wanted to talk about is, right, so we have to get a new schedule. So this Saturday onwards, what I'm going to do is I'm going to be discussing pediatrics, and we will start with breaking bad news in pediatrics. Okay, so that's our first topic. For the next 1 month, we will be discussing pediatric scenarios, starting with breaking bad news to parents. My YouTube channel name goes by the same name, Mybythebook. Yes, these are the same free sessions. I conduct weekly free sessions, and then I upload them on YouTube. So if you have missed any of the session, you can go on YouTube and you can see the session. It will be uploaded there the next day. Okay. However, I'll see you all on Saturday. I'll post more information regarding my sessions on my WhatsApp group and on my Facebook group. So if you're there, you would know. Please do join. I hope that it will be helpful. I hope that this session was helpful too. Please let me know if there are any changes you would like, so I can work on those too. Okay. Thank you so much for taking your time attending the session. I really appreciate it. Thank you. Thanks a lot.